Steve, do you have a question at this time?
Yes. I'm Jordan from Honolulu, Hawaii. And my question is, do you feel that the prep, the actual surgery, or the recovery is the most difficult step in the process?
So for the patient, the poor surgery is potentially the worst part. They're suffering and hurting, and they can't. A lot of people have night and rest pain. They can't walk, exercise, do much in the way of activity. So for some people, the before is actually the worst part. The recovery is certainly the work. So in the recovery here, our patient will be typically on a walker for the first couple of weeks and then progress off of that to a cane. She'll do home therapy for a few weeks and then progress to outpatient therapy for about a month. So it's about 6 weeks of work after this to recover, and a lot of that is therapy driven. To help with recovery, she'll be on pain pills to help her symptoms. And so that would be typically, as framed, the hardest part of the recovery. Would not be the surgery itself, because, but the recovery. The hardest part of the whole process would be the recovery part. Just cleaning more tissue. You can go with another question.
Austin, do you have a question at this time?
From Williston, North Dakota. And I was wondering what led you into orthopedic surgery as opposed to neurosurgery or heart surgery.
Well, I can't tell you why I didn't do neurosurgery, the real reason. Those people aren't very nice. No, I'm just kidding. Well, Sam can tell you why he became an anesthesiologist, and it's not totally because he's antisocial. But I went into orthopedic surgery because you get a chance in medical school to rotate through all of the different subspecialties or specialties as much as you can. Orthopedics to me is a very concrete thing, meaning there's problems that you identify and fix. It's tangible, there's outcomes that are improved, people get better from, and you get to use power tools. So who wouldn't like that, right? People get better, so you have very happy, appreciative patients, and you fix problems, which is in people's skill sets. You have to know what you like doing. Some people like thinking about things a lot. Some people like doing things a lot. Some people like seeing tangible improvements. They need that. And anyway, so orthopedics has a lot of that. Okay, so now we're sizing our tibia like we went through the process of sizing everything else. Okay, so we know that she's a 2.5 on the tibia as well. We'll go ahead and take this knee for a test drive. Okay, so we made some initial bone cuts. We're going to try and take it for a little test drive and see that everything works and fits, and if not, we'll make adjustments. So this is a trial 2.5 tibia, a trial 10 millimeter plastic liner. We're going to go ahead and place that. And then we're going to put our trial 2.5 femur in.
Steve, do you have a question?
Hold your question. Hold your question 1 second, Jason. Okay, let me tell you what we're doing here. So we're taking our knee for a little spin. Okay, I'll come right back to you. Go ahead and mute your microphone. Okay, so Matt shows from the side here. So our knee needs to come into full extension. So this knee easily comes into full extension. The camera angle there skews it a little bit, but this knee easily comes into full extension. And we want it to not be too loose. So overhead again, you are there. So there's a little bit of gapping, as you see right there, okay? So as I put a stress on that, that opens a little bit. So you can kind of appreciate that, how that opens. Now it's subtle, and you may think, well, that's okay, but we're going to try and make that a little bit better. Now as we go into extension, flexion, she got a little bit tight right there. So we're going to tinker with this whole thing a little bit, okay? So let's see a 2.5, 12, okay? Oh, I put my hand all here, right? I want that handle. Easier. We'll pull those pins.
You can go ahead with your question.
Go ahead with your question now.
So, as I was saying, what is the biggest risk facing this operation?
Okay, so risks are different for different people. Go ahead and remute your mic. Some of the risk is dependent on their preoperative medical conditions, okay? So somebody who's got bad diabetes or heart problems, they may have more of a risk. It's a little tight there, isn't it? And one more time. Up, just lift up on the back there. And then if you don't have big medical issues, okay, then the risks will turn into the standard risk for a knee replacement surgery, which are infection, bleeding, and blood clots. Those are the big ones. As those play out in people's recovery, we do lots of things to make those less common, but infection, bleeding, blood clots are the big ones. Now, the systemic risks, again, are dependent on more their underlying conditions. So somebody with diabetes has a higher risk for infection, somebody with heart disease has a higher risk of heart problems, and you go on a list of different medical issues. Okay, so this knee is going to require a little bit of tinkering for us to get it right. Okay, so our knee comes into full extension. You can see that it reaches full extension still. Go back to the overhead. We like our extension stability here. I would tell you that that is better. Okay, so there's not the same play that you saw before. It doesn't open the same. However, we take it up into flexion, and that's too tight. So there's a couple of different ways we could address this, and this is the size 2. So we're not going to downsize our femur and shift it up, so we'll take the PCL. Okay, so as we look here, we'll be seeing our posterior cruciate ligament is right here, okay? So you guys get a pretty good look at that. Can you see it on there? See it on there, Jim? You suck. Here's our PCL right there. So it's excessively tight as we go into flexion. And as I recess or release part of this, you can kind of see we gain a ton as far as our flexion laxity. So now what was really tight here a second ago is not. So now our knee has changed totally, so let's follow it up and down. So our extension was fine before, and as we take it up into flexion, you center that back a little bit. We're a little bit tight right there, aren't we? Jeez. I'd like her to be 11. You know 11, Polly? We got that? 11? No. So I'm going to say that, to me, that's a little bit tight throughout both, you know? And the 10's not quite right. So we're going to just take a little bit of a shave off of the bone on the tibial side. And we're going to take a millimeter, which is a very subtle thing. We'll do that with the computer. So to make it correct in both ways, I'm just going to remove just a little wafer of bone here, just so that we're stable all the way. So one more cut. That'll nail that. Okay. Steve?
You have a question at this time?
Go for it.
Hi, I'm Sunita from Missouri. How do you know if you've oversized or undersized the knee replacements?
Okay, so we're looking right at it. So you guys are too. It'd be real. Here, give me a size 5 tibia. Trey. I have a 2.5 in right now. They come in sizes. So use the analogy of shoe sizes or dress sizes or pant sizes, or so this is a 2.5 that I have on there. See how Jen put that on there? Fit real nice. That'd be a 5. So we're sizing it. We're looking right at it. So we're not gonna oversize it because we're matching our anatomy perfectly, and so as long as my eyes are still working okay, we're gonna be all right for that. All right, so really, I just took a millimeter there, and all I'm trying to do is get that so that it went, but I just want it to not feel so tight as it goes through. Okay, let's try this one more time. Upsy daisy. And that feels a lot nicer going in, I can tell you that right now. And here's our two. So you asked the question of not knowing, of oversizing it, and you know, this is sizing in both the anterior posterior direction as well as the medial lateral direction, right? And this knee is clearly not oversized. Okay, so we come into full extension, easy full extension, not too loose. And then we come up into flexion. We'll try that kneecap in a second here. Let's do that. Get that? Here's our trial kneecap button, which we prepared for right at the beginning, remember? We're gonna make sure that that travels really well, right? And then we come into flexion, and that's a lot better. So good stability, but not so tight like it was a second ago. Kneecap tracks really well. So this kneecap is supposed to glide right up and down in the center of the groove. And that's without it being closed and repaired. Just on its own, it wants to travel. Once we repair it, it'll be even better. So good stability all the way around, nice and easy, feels really good. That's a happy knee.